Hello, and thank you for joining today's webinar on the 2026 ICD-10 and CPT Code Updates. Unfortunately, October Boyles, our planned speaker, had an unanticipated conflict today, but we're pleased to welcome two outstanding subject matter experts from ICANotes to walk you through these updates. Larry Rogers has worked as a trainer at ICANotes since 2017, supporting clinicians and practices in effectively leveraging EHR and billing systems for behavioral health. His hands-on experience training users will help ensure practices are ready to implement coding updates smoothly. Rae Morris is a certified medical coder and biller with over 15 years of experience in behavioral health settings. She is currently an RCM Account Manager at ICANotes and is well-versed in guiding behavioral health practices through changing regulatory and coding requirements. Together, Larry and Rae will guide us through the upcoming 2026 changes, explaining what's new, what's changed, and what it all means for your mental health practices documentation and billing. So I will turn it over to Larry.
All right. Thank you, Sandy. Where we're going to start, we're going to talk about some of the things that we're going to cover in our session today. So our agenda is going to be to kind of let you know some of the updates that have been made to the ICD-10 codes, also any of the CPT codes or billing codes that they've updated and changed. We're going to talk about some of the payer policy changes, other documentation and compliance tips that we have for you. And at the end, we will have a short Q&A session. But as we're going through, if you do have any questions that you don't want to wait till the end, or you're afraid you're going to forget what your question is, you can also post those questions in the chat area on your screen there. So like I said, our learning objectives for today, we're just going to identify some of the key ICD-10 and CPT changes that are going to affect behavioral health. Okay, we're going to apply some of the documentation tips that are going to support those codes. And then we're also going to help you align the billing and telehealth integration policies so that try to help you avoid as many denials as possible. All right. So first off, starting with the ICD-10 codes, you can see they've made just a few changes, right? Added 487 new codes, which compared to the 74,000 codes that are out there, that is just a drop in the bucket. But they revised a few codes, deleted a few codes. These changes are effective as of October 1st and will go until September 30th of next year. Now, why did they make these changes? In general, they're just trying to provide some greater specificity, which I'm glad I said that because I'm going to try not to say that word again, but just to try to add that more specific information, give you some more granular subcodes, and just help improve the data reporting and give you better alignment with the clinical process. Okay, so what we're going to do is we're going to highlight some of these changes, okay, some of the ones that are going to be probably that you're going to be most affected by. Some of those are with the major depressive disorder. What they've done is they've expanded that to include the severity levels, the episode type, and so that you can include any psychotic features that go along with the depression. For the substance use disorders, we want to identify that remission, that they are in remission, and identify the drugs or the substances that they're using as well. For the anxiety disorders, they've actually added a lot of codes so that you can kind of differentiate between the different anxiety disorders, okay, such as panic disorder, generalized anxiety. Okay. The sleep and insomnia, again, just clarifying whether it's primary or if it's something that is due to a mental disorder. And then some of the pediatric, again, being more specific with those coding as well. Okay, so again, what they're trying to do is to move away from some of those unspecified codes, capture the severity levels, and then more specific information, more specifiers for that. Okay, so what we're talking about as far as the documentation, you must include that severity, the number of episodes or type of episodes, any additional features, and then of course that remission status for the substance use. Okay, what that's going to do is it's going to help support the ICD-10 codes that you're going to be selecting. Okay. So again, just going into another level of detail here, you can see some of the codes, some of the new codes that have been added along with the descriptions. Okay. And you can see how the descriptions do place an emphasis on whether it's a single episode or a recurring episode. The severity level is there as well. Along with the F32.1, you can see that it adds some of the anxiety features, other psychotic features, things like that. The far column to the left gives you an example of what your documentation should include. Now, with the ICANotes system, when you select that diagnosis code in your note, it is going to include the description, but we also want to have elsewhere in our documentation that same information. Okay, we want to state that this is what the disorder is. We want to state that whether it's a single episode or a recurring episode, along with that severity level. Okay. You can see also those granularity requirements. Again, for the episode type, we want to designate single versus recurring. We want to put in the severity level. We want to add any of those psychotic features and then any other specifiers that go along with it. Really, like I was talking about earlier, what they're doing is taking away kind of some of those where if you can't define it any better with a diagnosis code, a lot of times you would use the 32.9 in this example, which is the unspecified area. Okay, but now you're able to split that, or they've split that into more specific subcoding. So these subcategories give you those codes so that you don't have to use that unspecified option. Okay, so you get more detail. Now, along with the information that I showed you in that first column to the left, along with that documentation, we do have a ton of forms in our system that you can use these assessment forms. Especially in the example, you can see the PHQ-9, that can help support the severity level that you're stating in your notes. So you can see if they score a certain number on that PHQ-9, that gives you the support and the documentation to say, yes, this is that severity level that we've stated, but it also gives them that documentation and that support for that. Okay. Now, we've got a really nice example there at the bottom. Okay. But you can see we included the disorder, we included the episode type, okay, it's single episode. We included the severity level along with that supporting document, the PHQ-9, and then added some of the other features and specifiers that go along with that. Okay, so that gives you just a really good example in there as well. All right. Going into another one of the big areas here is the substance use disorders. Again, one of the things that they're wanting to make sure that you're documenting and everything is the remission information or the remission status. Okay, so one of the things that you do want to make sure to include is the terms in remission. Okay, you do need to explicitly state that that in remission in the notes. Okay, for anybody that's in a mild status or a mild severity, you would code it as abuse is in remission, okay, because they're just overusing. For anything that's moderate or severe, we want to code that as dependent is in remission because it is more of a dependent type of feature. You can see a few examples there. Again, what we want to state and you can see it in the examples, what we want to state is the drug or the substance that they're using, and then, state that specifically, and then also include the type of remission or the level of remission. So you can see some examples, whether it's sustained, it's early or moderate, those kind of things. Okay. What we want to get away from is, as you can see in the audit tip, is using vague terms. So we don't want to say just, okay, they have a history of this abuse. We want to kind of state that, again, just putting in more specific information, okay? So that specific condition or that specific substance use is in remission, and again, what kind of remission? Is it early, moderate, those kind of things, okay? So again, just that clarifying, that clarity information. So we've provided kind of a checklist here for you as well. So again, some of the things to think about when you're either reviewing your note or as you're entering your note, did I say that explicitly that this is in remission? Okay. Did I put in the substance type? Was it alcohol, opioids, certain things like that? Did I also include the severity? Did I say, is it mild? Is it moderate? Whatever it is. And then also, is it early? Have they sustained this for a while? Those kind of things. And did we use some of the supporting documents? We have NAM in our system. We have other drug assessments and abuse assessments in our system. Are you utilizing those? Again, we want to make sure that we're supporting the information that we put in there. Okay. There is also an option that you can include the time frame of the abstinence. So if they've abstained or they've been in remission for several months, days, anything like that, that's also something that can be included or should be included, and things that we do want to make sure that we've added in there. All right. Okay. So again, just a review, some of the things that we've talked about, but just summarize a few of those things. When we're talking about depression, again, we want to make sure that we record the episode. If it's single, recurring, we want to put in the severity. We want to include any additional psychotic features, specifiers, anything, again, that kind of gives us that background or that support to our diagnosis. For the anxiety, many of the changes are just specifying the specific disorder, whether it's panic attacks, PTSD, generalized anxiety, social anxiety, anything like that, along with the severity. Okay. Again, we're trying to get away from just saying they have an anxiety status or state or anything like that. Okay. Again, wanting to use some of the standardized measures so that we're utilizing those forms, those assessments to support and back up the diagnosis that we're coming up with. Okay? And those things can help you decide, is this a mild situation? Is it a moderate? Things like that. One of the things that is a new item here, they've added quite a few Z codes, which basically just gives you some more background on the patient. You can see in the example there how they've used the one for homelessness. So if you do deal with a lot of homeless people, then you can make sure to include that, the Z code in there. I know a lot of you are probably not real used to the Z codes or maybe haven't ever used those, but it's something to kind of look into, look at, because again, it can provide more information and more detail to give to the auditors or to the insurance company, things like that. But again, just taking a look at some of those, and if they apply to your patient, utilize them. Gives you that additional information and things that you're able to take a look at. Okay. At this point, I do want to also mention, you can see there's a handouts tab. We do have some great handouts that go along with everything that we're talking about today. So you'll have those available if you want to click on that. There's links in there that you can download those things as well. All right. And so moving on, I'm going to turn it over to Rae, and she will take over the CPT codes.
Hi, good. Hello, everybody. We are going to cover on this part of it about the CPT codes. All right, for 2026, there are going to be a total of 418 total changes. So to break that down, 288 new codes, 84 deleted codes, and 46 revised codes. Now, how many of these actually impact behavioral health? It's not as many as you think. It's going to be a few additions, and most of the other ones are impacting other specifications, like other like auditory, doing cerebral perfusion, like things that aren't really related to behavioral health. Some of the ones that are impacted for behavioral health are expanded remote and digital health capabilities, telehealth eligibility, which is a good thing, and the integration for billing pathways rather than brand new psychiatric codes. So that's like in reference to integrating primary care with behavioral health. Just to go over some of those that we're going to focus on is the remote monitoring, the digital health, the telehealth, and the collaborative care integration. All right. Okay, so with the remote monitoring and digital health, there are some new codes with that. All right, these are going to be related to the remote physiological therapeutics, and the remote therapeutic ones. Okay, so this is all for the remote monitoring. So this is where the patient's at home or elsewhere, not in the office. They have a device where either it's tracking their blood pressure, that's the remote physiological monitoring. Okay, their blood pressure, their heart rate, some of those basic functions there. And then you also have your remote therapeutic monitoring. That is where the patient is reporting things like how much they slept, what they're eating, are they doing their exercises, are they being adherent to that, are they taking their medications. Those are self-reported through these applications. So some of these new codes, where we had it in the past that you had to report it more time, like you had to have more time. They didn't have where you could do small little check-ins over a 30-day period. They had it where you had to have a minimum of 20 minutes or more, or 30 minutes or more, in order to bill it. So for those ones where you just do quick check-ins, is very quick, like 1 or 2 minutes. Now they have these new codes where you can do it for a shorter interval, a shorter amount of time over a 30-day period. Okay, so you can just check in 2 to 15 days, just check. All right. And there are some new treatment management codes that go with that. We're going to go over that in a little bit more detail, but if you're looking for the codes, they should be on the handouts. And if they're not, it's like 99470, 99457 through 58. It's just a variety of codes, but those are some of the new ones, and they're just making it more sustainable so that your documentation doesn't have to be quite as thorough as it used to be. So it fits more in there. All right, so this is just to help monitor sleep patterns, things like that, because you've probably had some patients or clients and experience where their sleep is not good. So then it's going to cause them anxiety or depression, or maybe they're sleeping too much and that's causing an impact on their mental health. So that physical health does impact mental health. I actually remember when working in a facility where sometimes the patients would have a urinary tract infection, and it would cause like psychosis. So you can see how those things can relate. So being able to track these things is really helpful on a long-term basis. And it's not really hard to document either. It's basically just saying, this is my review, this is how many minutes are spent doing it, and then you report it once a month. And this is the part that a lot of people tend to ask about, the telehealth flexibility for behavioral health. Okay, so the COVID waiver was for Medicare, and we'll cover this on the next slide too, was until September 30th, 2025. So what we've got going on now is that you have your patient gets to decide if they want to do video or audio only. There are some situations where the patient will decline, that they don't want you to decline the video, so you have to do audio only. Just knowing that those are options, and it's going to be accepted by more payers, okay? What you do then, you just deliver the service, whichever, whether it's audio visual or if it's going to be audio only. You document it accordingly in your notes. If you're doing audio only, document that you did audio only. And then what you'll do is on the claim, most of the payers are going to want a place of service O2 or 10. Okay, and O2 means that they're not in their home, and 10 means they are in their home. Okay, and that's where the patient is located when you are providing the service, not where you're located. A lot of those you're going to want the modifiers. There's a 95 modifier, GT modifier, there's a FQ modifier, and a 93 modifier, and those are some of the more popular ones in regards to telehealth. Okay, now I'm just going to break this down for you because I know a lot of people are like, what FQ and a 93? What is that? Because we're familiar with the 95 and the GT, and you're going to use the 95 and GT based on what your payer requires. Because like a Medicare Advantage plan is always going to want a 95 modifier with a place of service O2 or 10. Okay. But Medicare might not want a modifier. They might just want the place of service O2 or 10 because that works for Medicare. And you may have a payer that says, I want place of service 11 with a 95 or a GT modifier. So you really got to look at your payers because that's what you're basing that on. Okay. But now going back to the FQ and the 93, the FQ modifier, that is for a federally qualified health center. Okay, you have to be certified for that, so you will know if that applies to you because you would have that certification. Or if you're a rural health clinic, an RHC, okay, and that you have to go through like a whole state evaluation for that. Again, you would know if that applies to you. You can't just say I'm a RHC or a FQHC. You have to have the qualifications and go through and meet that certification or that evaluation. All right, so that's a FQ. So probably most of you aren't going to use a FQ that often. If you are, you'll know that applies to you. The other one is a 93 modifier, which is not on here. That is identifying that it is audio only. And again, you have to refer to the insurance just to make sure that you're meeting their standards for when to use a 93, like when it's appropriate. Some payers don't care, some payers do. So you really have to look at their payer policies. But there's a lot more flexibility because before it was like all audio visual and very minimal audio only. So now they have a lot of flexibility with that, especially Medicare, who is the one who was setting the standard for most of the rest of the U.S. All right. Now, we're going to come back to some more about Medicare and telehealth. I want to talk about the collaborative care model. Okay, that's the COCM and integration. All right, now this is when you have a primary care practitioner services and you're integrating behavioral health into that. Because like we were talking about earlier, those physical things can impact the mental health too. Okay, so what this collaborative care model does is you're going to have this advanced primary care management, right? And they're all going to come together, and it can have a I'm kind of like specificity. You're going to have the disciplinary team with a lot of different types of issues. Okay, so when you have that, some of the new codes that they have is where that advanced PCM or that primary care management, like that provider, is going to be able to bill for some of the behavioral health services that they're integrating. Okay. All right, we already have some codes for that. That's the 99492 and the 99494. Those are still existing. They did not change at all, which is great because we've got enough changes with codes as it is. And they still have the general behavioral health integration code, which is a 99484. Okay, so that will still exist. All right, so the new codes we have G codes already too that exist too, for like if somebody has a one or less chronic health problem or two or more, or if they have two or more chronic conditions and they're also a qualified Medicare beneficiary. All right, you ever see that QMB when you're verifying benefits and you're like, what is that? These are the people that we're talking about where they have G codes. So now they have these other codes that you can add on for that collaborative care. So G0568, that's covering the initial month, okay, for when these services are being done by a primary care provider. All right, you got your G0569, that's for subsequent months. So you got your first month, you use that one time, and then you have the subsequent months after. That's going to be the second code. Now that third code, that G0570, that is when you use an additional 30 minutes per like month, because they'll have time frames that you're going to use within there, okay? So you can use that, add on that additional 30 minutes on that first G code or that second G code, either one. Now, the reason for these codes, and another key check here on the screen, is prior to 2026, you couldn't bill the collaborative care model codes and the primary care management in the same month for the same patient. So they had a lot of different, they had it where, okay, primary care bills primary care in their month, and you couldn't do the collaborative care in the same month because they were saying, oh, that's inclusive services, but that's not really how it always works. Dealing with medical, strictly medical, and then dealing with behavioral health, strictly behavioral health, they go hand in hand to me. So that's why you've got this collaborative care model and integration where they're actually providing you codes that can be billed and paid, because we all know we can bill codes all day, but will we get paid? So those are some changes that are coming to 2026 to make it so that the patient doesn't necessarily have to go to 5 different specialists. We can simplify that to at least 2 or less. All right. Some things you want to do in preparation for that is to make sure that you are updating your billing systems with those new G codes. All right. So especially if you're already using ICANotes, you want to make sure that you go into your settings and you add those codes to your short list if those are the ones you're going to be utilizing. You want to make sure that your health record, your HR or EMR, that they can track both the advanced primary care management and the collaborative care model time. Okay, because it's timed. You want to make sure you're getting paid for your minutes, right? We all do. And we also want to make sure if you are a rural health clinic or federally qualified health center that you add those codes to your charge masters. All right, because you'll have a specific system for that. Most do. All right. Y'all, I get to talk about these codes. I get so excited. Just bear with me. All right, this is what I was telling you about before with the Medicare telehealth extensions for mental health. You remember I was telling you that the COVID waiver, and I'm going to go a little bit backwards on some of these little parts here. That COVID waiver was suspended for the in-person, where you didn't have to do an in-person visit with Medicare patients all the way until September 30th, 2025 because of COVID and all of that fun stuff. So now, effective October 1st, if it is a new Medicare client, they have to have an in-person visit, okay, before they can have a telehealth visit. So if you're a Medicare provider, you need to see that patient in person. If it's a new patient, October 1st, 2025 moving forward, you need to see them in person first. Then you can render telehealth services after that. Now, if you are working with your Medicare provider, you're already working with patients that are established, okay, that doesn't necessarily apply to you. You can still see them, but they need to have an in-person visit within 12 months. Okay, and they need to have it once every 12 months. And once you get the new patient visit done and you're rendering those telehealth services, that will also apply to them. So they will need to have one visit that's in person every 12 months. And this is for your Medicare patients. And it's Medicare traditional, or if it's a Medicare Advantage plan, they have to have at least one in-person visit. All right, something else that is a permanent flexibility, and I just like to cover that in-person thing first because I always get those questions. Permanent flexibilities that are going to be forever, there's no more geographic restrictions, okay? They can be located anywhere for telehealth, including at home, so they can be anywhere, right? Anywhere. The home as the originating site, if that is something you're billing for, the originating site, their home can permanently serve as that originating site for the mental health services. Now we're talking about mental health, okay? Also, the virtual direct supervision is permanently allowed now. So if you are a provider and you have to be supervised, have direct supervision, that supervisor can join on virtually. Okay, whether you're seeing that patient in person or they're virtual as well, that supervisor does not have to be in person. Okay, and they do allow for the originating site facility fee. We already got not everybody gets paid for that. Again, you have to meet the requirements, but that fee is being increased. So if it's not something you're doing, you might want to consider that. All right, and also the rural health clinics and the federally qualified health centers, they are distant site providers. All right, they can permanently deliver mental health via telehealth. So that's awesome because, again, we weren't sure how long we were going to have that waiver available. Those particular sites, you're good to go through the dawn of time. All right. In the audio coverage, when we talked about that briefly, they are allowed when video is not possible, if the technology is a barrier or whatnot, or the patient declines the video. So we talked about that and the modifiers you want to use. Most commercial payers want the 93 modifier. Just throwing that out there, but you do want to check with the payer policies just to confirm that. Some of the payer policy updates for the digital therapeutics and the integration. Now, we were talking about that remote monitoring before, okay? This is a digital world these days. Everything is digital on an app, online. One of the things that the FDA cleared is that you can use your digital therapeutics for ADHD treatment starting in 2026. Now, it was already cleared by the FDA for substance use disorder and insomnia. So that's not brand new, but the ADHD treatment is. So 2026, the FDA has cleared that you can use these devices, this digital therapeutics, to help treat the ADHD. Something else, provider expansion. Now, you guys might not have known this, maybe you've heard about this, but LMFTs and LPCs are now Medicare capable. They can be Medicare billable providers. This actually went into effect January 1st, 2024. Okay, but not everybody, again, it takes a little while for everybody else to get on board. But if you are an LPC or an LMFT, you can get credentialed with Medicare. You are going to be a Medicare billable provider. And if you don't want to get credentialed, you can be a in-network or out-of-network. But you do have to go through the documentation. You do have to go fill out the forms if you want to be out-of-network, just so to prove that you are an approved provider. And that's really fun too. But it's good that this expanded. So it's not just psychologists and doctors and nurse practitioners and social workers. It's LPC, so your licensed professional counselor, and your licensed marriage family therapist too. All right. For billing structures, we were talking about, I was thinking about for the FDA cleared digital therapeutics, they're typically billed incident to. That's not changing. You usually want to keep that for those particular codes. With the commercial plans, again, we're talking about the digital therapeutics. Lots of the commercial payers are starting to open up pilot plans for that, just saying, hey, we're going to try this for a sample. And if it's successful, then they'll probably open it up wider, right? But you do, if you're going to be one of those people who are testing that out for the commercial plans with the commercial plans blessing, you do have to verify that the patient has coverage under their plan. And if prior authorization is required, as you may know with some of these things, especially I saw somebody had a question about the psychological testing and neuropsych testing. Sometimes you have to have an authorization for it. So you do want to make sure that you check those if you're going to pursue the digital therapeutics as part of your regular practice. All right, and then with Medicaid, they are expanding coverage for peer support services and mobile crisis interventions using some new HCPT codes. That's just what we call it, but those are basically CPT codes. They're just letter-based. So those are, Medicaid's just expanding that so much especially with the need that we have right now in the behavioral health world. All right. Most importantly, when you are working with any type of service, you do always want to make sure that you verify the medical necessity criteria. Okay, so if you've ever gotten a claim denied and it doesn't meet the criteria for medical necessity, you have to go and you have to look for those things within the payer. Now, once you figure out a couple of them, you'll be able to trend it and you can say, okay, I know I need this authorization, or hey, this says it needs authorization, but it really doesn't. You really start to figure that kind of stuff out. So you do want to make sure you check for that medical necessity. You want to check if that particular, especially with digital therapeutics, if it requires prior authorization and if supervision documentation is required before you implement these digital therapeutics in your practice. Now, this could apply to everything, not just digital therapeutics, but especially with that, because it's a newer, more popular treatment method or supporting treatment method that I suspect is probably in the next 2 or 3 years, it's just going to be the norm, kind of like telehealth, right? So if that's something that you're interested in, just make sure that you verify those requirements. All right. Now for that collaborative care documentation, I know we're going a little bit back and forth, but these all tie into one another because it's all about pulling in that data, pulling in that information and working on it from a big picture point of view, right? So some of these things for documentation that you want to make sure you know is that it's time-based monthly billing. Now this is for that collaborative care model, right? Track your minutes spent by the behavioral health care manager and the psychiatric consultant each month. Now it's up to you whether your documentation, you just want to do like a one little note every time, or if you want to have a running note with the dates inside of it. Either of those is fine because it is monthly billing and you just want to send in that one piece of data. If you had to report that note and submit that note, that would be one note, or you can do multiple ones. All right, but it is time-based monthly billing, so you do want to make sure that you track those minutes. All right, for the required elements, have to be in a patient registry. All right, that's just the basis. You want to make sure that you're using the rating scales that are approved. Everybody knows our PHQ-9, GAD-7 are our favorites. You do not have to have a copy of the test there. You just need to document that it was administered, when it was administered, and what the score result was, okay, because we're tracking the numbers. All right, you want to make sure that you have those weekly psychiatric case review notes. Okay, so even if it's just a couple minutes, you're just reviewing those notes. If you've ever been in a treatment plan group where you've got everybody in the group and you're going over the cases, that counts. Okay, you just want to make sure that's documented, that it was reviewed. Proactive outreach. You want to make sure that you're contacting the patient and just making sure that everything's good. Same thing like when you have a procedure done and then they call and the facility calls and they call you up and they ask, say, hey, how you doing? You know, everything okay? Do you need anything? Stuff like that. You want to make sure you're being proactive. Don't wait on the patient to call you when you're doing your documentation for this kind of thing, okay? And you want to make sure you adjust the treatment plan accordingly. All right, so if adjustments need to be made, that's what you do. Make sure that's documented there in the chart. Now for consent and compliance, you only need a one-time patient consent for the collaborative care model, okay, for that program. And you need to include that with the cost sharing notice, so what the patient owes. That way they're not hit with any kind of surprise bills. All right, so one-time consent, you're good. And you want to make sure you're not double counting. So your collaborative care, the time that you're doing that does not count or include your face-to-face therapy, your telehealth therapy, if they're seeing the psychiatrist or it's an E&M visit, those are separate. It does not count towards the collaborative care model program, okay? So like an example of that, we have a log here. So let's say on November 5th, you call the patient and you just make sure like, are you good? You're taking your medication. Are there any issues? Like a care manager can do that, sub 15 minutes. November 10th, there's a case review. All right, in the psych consult. So the psychiatrist is just reviewing the information, looking at the case, signs off on it, takes 5 minutes or less. Then there's maybe another follow-up call Okay, PHQ is administered, PHQ-9 is administered, and you get the score. Everything looks good, not good, middle, whatever you need, whatever the results are, you document that. That care manager can do that 10 minutes. So you can see the rest of the information, and you'll see at the very bottom as a registry update. So that's why they have to be in the patient registry, so that there is a database that can hold all this information and can help you track and trend it. And you'll see at the total at the bottom is 35 minutes. So just what you would bill once that for that month would be the 99493 if it's already an established patient. So that part of it, it's just little, not quite time consuming things, just some little visits here and there to check it in. It'll increase the quality of your patient care, right? And it'll decrease probably some of the bigger things that could be happening with clients because they know you're going to check in on them, right? And it's a little bit extra money that you're not leaving on the table. That's with the collaborative care model and digital therapeutics too, that can all be incorporated together. So some of the compliance tips in regards to telehealth and remote services. Medicare does require audio-visual, all right, unless the patient's not able to do or if they decline. Again, document that in your note. All right, because Medicare will say they want justification for audio only. All right, make sure you have the consent for telehealth. All right, one time. Medicare only requires it one time. You don't have to do it every visit. Some of the other payers, you might want it once a year. Most of them are just going to say once you have it on file, that's it. Like you're good to go. Your place of service codes. I think somebody asked a question about, I got a few questions about place of service. This is not on here, but just so you know, place of service 11 is office. Okay, that's like saying that you're in the office, like the patient's in the office when you're seeing them. Now for telehealth, place of service 02 is when it's telehealth provided and the patient is not at their home. Place of service 10 is telehealth service provided, the patient is at their home, at their residence. All right, and the modifier again is usually a 95 or a GT, and it's based on the payer. You do want to document where the patient is in your note, all right, and then make sure that matches what you're putting on your claim. So if the patient's at home and you put in your note that the patient's at home and you put place service 10, that's not right. Or that is right. Yeah, place service 10, you're doing good. But if they're at home and you put place service 02, that's not accurate. You want to make sure it matches up, especially since you have it documented in your note. All right. For remote monitoring, those new short duration codes, like I said, is 2 to 15 days now. It's usually more than that, 16 or more. So we've got a smaller 2-week time frame for that remote monitoring, which helps so you can bill like every 2 weeks. All right. You do want to make sure that you log the exact days, all right, that you're collecting this information. And it's very short, sweet. You don't need anything extra more than that. That's why I like that remote monitoring. It's pretty cool. Make sure you record the minutes that you're doing RPM or RTM. Again, the difference is therapeutic monitoring versus physiological monitoring. And you want to do your medical necessity. Justify that the service is needed, right? That there's a risk level involved and you want to keep them to where they maintain stability or that you're working towards that. Okay, so justify that service. All right, especially for those new digital therapeutics, because again, this is a newer thing and you'll start to see more as you go. And you do want to make sure too, when you're doing digital therapeutics, just in general, you want to make sure that you're linking that to the service you're providing. All right, an example here, digital CBT, your cognitive behavioral therapy, app prescribed for insomnia after inadequate response to sleep hygiene. And prolonged services, just make sure you're documenting those complexity factors so that it supports the codes that you're using. All right. Okay, and some action steps and key takeaways. Implementation checklist. These are really important things when you're making these changes and updating for ICD-10 and CPT, is you want to make sure that you update your EHR systems and your templates, all right? Your settings, your templates. your documentation, especially if you have, like in our system, we have these awesome custom buttons. Just make sure that you're updating those to reflect the verbiage that's needed to meet the criteria based on the insurance. You want to make sure that your code libraries have the new ICD-10 codes for 2026. Now, these started October 1st, 2025, and they update October 21st, or October 1st, 2025. Sorry, not 21st, October 1st, 2025. And then they do a little update on April 1st, because it's October 1st, big one, a little one on April 1st. You just want to make sure that that the system is updated with these new codes, that, whatever system you're using, and that the CPT codes are also reflected in those code libraries and the Medicare codes, because they like their G codes. All right. Provider education is also important. You're going to have to train the providers for these changes, whether you make a memo and then train them so that they have that on there, especially on how to specify for depression. All right, because they want you to be more specific. Single episode, recurrent. What level is it? Is it mild, moderate, severe with psychotic features, severe without psychotic features? Is it in partial remission, full remission? These are all things that we want to make sure that you code to the highest level of specificity, especially with the diagnoses, because a lot of payers are really locking down now. Even some of them are saying that they don't want you to use adjustment disorders more than 6 months. They're really locking down on those. Just want to make sure that you train your providers so that they're aware of these changes and follow through appropriately, and with the coding. Okay. And that's just not with the depression specificity. It's for the substance use, remission documentation, anxiety disorder granularity, and how to document for these new code requirements. Okay. And it's just a little bit extra. It's nothing, probably too much more than they're doing already. Okay. Refresh telehealth, update those workflows, okay, for the documentation. Video versus audio only. Make sure they're using the correct places service codes. Most of you probably already have this in place, but you do want to do a refresher just to make sure everybody's on the same page and they're doing this documentation correctly. Modifiers are appropriate for what the payer requires, and that you have your patient consent on file, okay? And then that's part of your basic process. Like I said, most of these payers want one telehealth consent form like completed, and then you're usually good until, they discontinue treatment. If you're not sure, I find it a good practice just to go ahead and do it once a year. And then that way you have that documentation to support it, no matter who the payer is. But that's just a recommendation. You can do it whatever is based on what the payers require. Okay. If you're going to implement your collaborative care model program, go ahead and you stand it up, expand it, configure your monthly time tracking tools, and make sure you have the consent for those mechanisms you're using to capture the data, okay, for that integration billing. Just want to make sure you have your plan together, your documentation requirements clear and concise, and then what codes that you're going to be using to submit those claims. All right. And you do want to make sure that any new codes that you use that you haven't been using, make sure that those are on your fee schedules for the different payers. Okay. You can just, usually you can just call the payer or your provider representative for that payer and see about getting that added to your fee schedule. All right. For the remote monitoring, if you wanted to use one of the pilot programs that may be provided by certain payers are doing that. If you want to do that, make sure you test them for those appropriate behavioral health conditions. You want to make sure that you're working with your small sample group just to test it, see how it works. And if you find that is working for your practice, awesome. Then you can just expand upon that and move forward. You do want to make sure that you establish logging the data for 2 to 15 days and longer. Okay. And because of these new codes, you can test it out on shorter periods of time, which is really nice. All right. And then don't forget to conduct audits. Lots of people are scared of audits. It's an audit. Oh no. But audits help us figure out where our weaknesses or where our weaknesses are and where we can build our strengths. So it's not always a bad thing. It's strengthening up your practice as a whole, your organization as a whole. So if you do these internal audits, that's going to help protect you from the external ones, right? I know I used to hate audits. That's no, why? But then you start to become more confident, see where, like I said, where you need to strengthen and things you may not have realized that you were doing incorrectly or what you're doing correctly. But those internal audits are huge. So make sure that you run those regularly, okay? Especially for coding specificity, right? And for those time-based services, all right? And you usually want to do those before the coding changes go into effect October 1st, and you want to do them before January. All right, because that's where that CPT codings change. So you got October and January. You want to make sure you put those things in place, do those audits before year end so that you're also updating your system at the same time. So these are just all parts of your implementation checklist that you want to make sure that you go through, and you can mark this off your list before end of year, definitely. Okay. All right. And just the level of specificity for the codings. I just have to stress this because I'm seeing a lot of this with different payers. Code to the highest level. If you're using unspecified code like depression, unspecified, you won't be able to use that for a super long time. You maybe for like your first several visits, but you want to make sure that eventually you move it on up to, hey, this is a single episode mild, or, oh, this is recurrent, moderate, so on and so forth. You do want to get more specific the longer you see that patient. All right. And like I say, you'll start to see these changes where they're really scrutinizing it for behavioral health because they want something more specific. All right. And it's just good reporting in general so that we can get an idea of what level of depression, just as an example, that, that most of these patients are exhibiting. All right. So we're here on our last slide for a Q&A. Normally your contact person would be October. I'm going to try to see if I can go through some of these questions over here on the chat. Before I do that, I do want to let you know that there are lots of resources out there. So you have your ICD-10 2026 addenda and guidelines. Okay, that's on the CMS website. They do have a downloadable one that you can just download into Excel or a CSV file. You do have your AMA CPT 2026 release notes. Those are going to show you the changes. Like I said, it's only a few. Thank you for affecting behavioral health this year. All right. But ones where you can see what back in the day we would say were futuristic. These are becoming real life options now, especially that remote monitoring. All right. You have your fee schedule for your physician fee schedule. Most of that's on the CMS website as well. And you have your telehealth policy hub. So those are just updates on those requirements. All right. And you'll find that on hhs.gov. All right. Let me see if I can walk through some of these questions. I believe I answered one about the places service. Oh, you got that one. Okay.
Rae, there was one about the EMDR, if that's considered a digital therapy.
It is not.
Okay.
EMDR is not. Yeah, I believe they code that just as a regular face-to-face therapy session. As far as I know, they haven't expanded on that, but it would be really awesome if they did. We had a great convention in Atlanta like last year, the year before, just for EMDR. They had a lot of really good information about that. I did see a question, is there a new separate CPT code for audio only? If you're doing therapy, you can use your regular therapy code or your ENM code with the 93 modifier for most payers and as long as you have it documented in there, that's fine. There are codes that are for telephone only, like if you're just doing like a quick check-in. Those before, it was like 99441 through 99443, I believe. but those got deleted January 1st, 2025. So it's been almost the whole year. They did get replaced with some other codes. And again, I think it's 98008 through 98015. Yeah. So they were replaced. You could use those codes if you want. I will tell you the reimbursement's not going to be as great as if you used your regular codes with a 93 modifier. So just something to think about.
Okay.
Is there any way, I know someone asked if we could expand on what digital therapeutics would include or what it is?
Oh yeah, so it's basically if you have it's an app or like a smartwatch, right? So if you're using this or it's a different application, like it has to be approved, of course, by the payer, but something that's tracking some of these things for you, for the patient, without you having to be there. Now, there are devices that you can purchase as a practice, and you want to make sure it's approved by the payers first, okay, before you go and invest in that. And then you can, it's like a lease, like you're leasing it to the patient. Now, patient doesn't have to pay for it, but you can bill that code that they're using one of your devices and have it reimbursed by the different insurance companies. And again, it depends on the payer. So it could be something like a pedometer. It could be like a little smartwatch. It doesn't have to be Apple or super fancy. It could be whatever the approved device is for the physiological, the RPM, that digital monitoring device. Okay. And then it'll send the device, the information to your main system, right? Like Apple does, or even Samsung, or I don't want to be biased, but they'll send that information back. Like you can pull that data and then gotta go from there and then do your outreach. But that's what that is. Now, if it was the digital monitoring with the remote therapeutic monitoring, that could just be an approved app that's on the patient's phone, and they're putting in, yes, I took my medicine, I drank 8 glasses of water today, I slept 5 hours last night, things like that. I went and walked for 30 minutes today. That's just what they're self-reporting on the application. So that's what that's about.
Thank you for watching today. We hope you enjoyed our webinar. At ICANotes, we're passionate about providing mental health professionals like you with the most clinically robust and intuitive mental health care software available. From psychiatrists to therapists, nurse practitioners to social workers, ICANotes offers a comprehensive solution tailored to your practice's needs. With ICANotes, you can write a flawless note in less than 3 minutes, and without typing a single word. ICANotes was designed specifically to help mental health professionals write comprehensive notes quickly. ICANotes also provides a complete practice management solution with user-friendly scheduling, secure document management, HIPAA-compliant messaging, a certified patient portal, and more, so you can spend less time on paperwork and more time helping your patients. Try us free at icanotes.com/try-us.